everyone, let's go ahead and get started. Thank you for joining us today. On behalf of my co-chairs, Drs. Jenny Shang and Karen Smith at the Johns Hopkins Breast Cancer Program, we'd like to welcome you to this three-part COVID and breast cancer webinar series. My name is Alyssa Thorner, and I'll be moderating this event for today. Over the next hour, we'll be discussing breast cancer treatment implications for patients undergoing care during the COVID-19 epidemic. The ideas for these webinars came from many questions we were receiving from patients like you as to how treatments, protocols, and support may vary during this very challenging climate. As a result, our team has recently just published recommendations on COVID and breast cancer treatment in the Journal of Oncology Practice. The article is expected to be out very soon, and much of the information you'll be hearing today came directly from the manuscript spearheaded by Dr. Shang and Smith in collaboration with Johns Hopkins surgeons, radiation oncologists, medical oncologists, pharmacists, plastic surgeons, and patient advocates. During today's webinar, we'll be discussing surgery, plastic surgery, HER2-positive breast cancer, triple-negative breast cancer, ER-positive breast cancer, and radiation oncology, so it's definitely a packed agenda for today. We'll also be hearing from one of our patients, Susan Longley, who's currently going through treatment during this very difficult time. Ms. Longley, who is a nurse and an attorney here at Johns Hopkins in the risk management department, will be sharing her experiences of dealing with the stresses of treatment and how it's been compounded by the COVID epidemic. A few housekeeping items I want to go over just before we begin. I have your line muted and your cameras off. At any time during the presentation, if you have a question, please feel free to use the chat feature you see on your screen. Your questions will come directly to me, and we'll get to as many questions as possible at the end of the webinar. If you miss any of the presented information or would like to see it again, we're recording today's event and we'll be sending out the link in the next several days. And finally, at the end of the presentation, I'll be sending out a post-survey link. The survey will only take you about a minute and will really help us get feedback on how we did today and how we can improve for future events and programming. So that's about it from me. I'd now like to turn it over to Ms. Longley. Ms. Longley, are you there? Let's unmute your line.
Thank you. Hi.
Thank you so much.
Good afternoon. I appreciate the opportunity to speak with y'all. This is, it's been a very interesting time, I can tell you. So I think just some brief comments, and I apologize that I've made some notes, so I'll be kind of glancing down a bit. Obviously, it's a very personal journey whenever you are faced with a new diagnosis, such as breast cancer. And I think really where you begin and how you really relate, it kind of depends upon where you come from, right? Like, what's your background? Do you have a healthcare background? What's your experience? Do you work for a healthcare system? Are you a total lay person, have no experience other than perhaps health issues yourself or health issues for people that you love? So, you know, what is your experience with the healthcare system or the healthcare environment itself? And then also really who you are as a person, I think is really important at this point in time, because we're faced with having to be even more self-reliant than you might otherwise have to be, right? So some of the processes, instead of having someone able to come to visits with you, you're not able to have that. And so it, you know, it's just a different scenario for a lot of folks. So that's all very relevant to what we're talking about today. And so if you are just starting your journey, I think this is your normal. So you're not going to really undergo or deal with a lot of the stuff that that I dealt with, because actually my diagnosis, my notice of a positive biopsy was right as everything was kind of ramping up with the pandemic. And we were still trying to figure out what was going to happen. There were so many unknowns. Were the hospitals going to be overwhelmed? Was there going to be enough personal protective equipment to deal with COVID patients, as well as those who have other health issues and, you know, who still need healthcare services? So it's been very interesting. But again, if you're just starting out, this is your normal. You're going to be used to face masks and wearing face masks yourself, meeting everyone with a face mask, social distancing, and all the different rules related to who can accompany you and participate in your care. So as was mentioned, my background, I was a trauma critical care nurse before I went to law school. And I have been working in healthcare for a long, long time. I honestly was a little more comfortable with everything than maybe other folks might have been, because I'm a longtime Hopkins employee. I am responsible for risk management, patient care issues, ethics, regulatory matters. So as I'm dealing with this as a patient, I'm also dealing with kind of the rules that were being put into place through what I do, right, through my work. So that was also somewhat interesting. Let's see, how this really impacted me personally. As I said, the timing was such that there were so many things that were unknown, and things were really swiftly changing. So I had a surgical plan, and that original surgical plan changed within a week because of restrictions that were put into place related to what kinds of procedures were going to be allowed. And the concern, of course, again, was because of whether or not there was going to be enough equipment. Should our staff be present any more than they absolutely needed to be, the types of procedures that were being allowed. So that all changed, and I had to quickly make a decision about what the journey was going to be, what my procedure was going to be. So that was a little disconcerting, obviously, but honestly, it's worked out beautifully. I did go through kind of the evolution of the in-office to video and telephone visits, and I'm very much more of a person. I like face-to-face. I like being in person as opposed to doing Zoom meetings and video visits or whatever. But honestly, I got to say, I've been very, very surprised. I'm a convert to Zoom. I'm a convert to video visits. Looking on the bright side of things, when you're not feeling well, it is a really easy way to connect with your healthcare provider. It's very personal. You do have the opportunity to see face-to-face as opposed to the two of you being in a room with masks on. So, looking at the positive side of things, that honestly is a wonderful thing. You can connect and you're not feeling well, and you don't have to get up and try to get there. The other issues that I was dealing with during this time was, as I said, staff were being sent home, not just clinical staff, but also administrative staff. So just trying to get the appointments made in a timely fashion, all of that was a challenge. But honestly, that's all worked out now. So I think that has gone very well. And then the hospital, of course, was, as I said, was developing the procedures for when patients would be actually coming to the hospital or the clinic or the infusion center, and developing these different rules. So I think that I'll just end in saying that honestly, there are a lot of silver linings. There's a lot of good news. I think at this point in time, more is known as far as what to expect. COVID's going to be with us for a while. So again, this is our normal. I think we still have some unknowns about whether or not there are going to be periods of resurgence and possibly restrictions having to be put into place again. So those are things that folks will have to deal with. But the administrative and the clinical processes have been worked out. And as I mentioned, the video visits, I'm a convert. I think they're great. And it also, honestly, you can, through that, through the technology, you can have your family and or your support, whoever that would be, participate, right? And we were able to connect and have everyone be able to participate in a conversation with the healthcare provider. So that works also. And then ultimately, like right now, I'm still going through chemo. And you go, and I'm not having anyone accompany me, but that's not necessarily a bad thing because honestly, you get to focus totally on yourself, and it's hard. It's hard on the family and the people who love you. So it's kind of good to be able to just focus at that period of time, focus on yourself. So I guess that's all I have.
Thank you so much. I thought that was really wonderful and really helpful to hear. I really resonated with me when you said this is your normal. This is what you've experienced, and you've been sort of through this throughout COVID, and so there isn't much to compare it to. And I think for a lot of patients, it's important to hear that we are sort of making this to be the new normal, and that we're adjusting our policies and to make sure that we are addressing hopefully the needs of patients. And then the idea that your optimism of the glass being more half full is really, I think, so important. That the face-to-face videos that you were talking about, it's a really great way to think about your family can join you, and we don't want to cram 10 family members into an exam room even when there's not COVID. And so it's a way that you can have family members remotely join you to these visits, or be a part and take notes and connect with your providers on a different level. So I think that's great. And the idea that you can look at chemo as a way to focus on yourself and hopefully have some peace and quiet during a very busy time, all really great tips. So I appreciate you sharing that with this audience, and thank you for your strength and your candor for sort of explaining what you're going through. I'd like to go ahead and switch gears a little bit and turn it over to Dr. Oyhus. Dr. Oyhus is a surgical oncologist here in the breast cancer program. Is going to be talking to you a little bit about how COVID has changed from a surgery perspective. And I'm going to ask Dr. Jenny Shang if she could share her screen to show Dr. Oyhus' slides. Great. Dr. Oyhus, are you there?
He's muted.
Let's get you on. Dr. Oyhus, can you hear us? It shows that you're off of mute. Let's see.
It may be the headset.
Yeah. Dr. Oyhus, if it's okay with you, why don't we go ahead and if you can you hear us now? Okay. Jenny, can we switch over to, let's go ahead and skip and we'll go, I know, let's go ahead and just go to Kristen. Dr. Broderick has got to be back in the OR. So why don't we start with Dr. Broderick, and we'll go back to Dr. Oyhus in a minute. So Kristen Broderick here is an assistant professor in the Department of Plastic Surgery, and we're going to talk a little bit about how breast reconstruction techniques have changed during the COVID epidemic. Dr. Broderick, can you hear us?
Yes, I can.
Fantastic. Thanks so much.
Can y'all hear me?
We can.
All right, and forgive me. I'm so thrilled to be here to be sharing this, what we've experienced from our end, and how we're working on trying to make things better for patients. But I will tell you that I am in the OR right now, so sorry for my attire and the mask on. I'm taking it off to talk. But if you want to advance to the next slide, I'm going to go through a little bit about what we've done. There will be some nudity. My patients have given disclosure for this, but I'd appreciate it if people wouldn't share this all over the web. Otherwise, I have nothing to disclose. So traditionally, when we talk about surgery in the setting of breast cancer, and many of you have probably gone through this, but I want to kind of show what we talked about, what we would traditionally talk about, and then how things are a little different. The surgical oncologist, so Dr. Oyhus will be talking to you a little bit about your options surgically in terms of the oncologic ablation, which involves either a lumpectomy, a mastectomy, either skin sparing or nipple sparing. And next slide. The reconstruction that I'm going to talk about is basically in that setting, whether or not we're doing oncoplastic, implant-based reconstruction, autologous reconstruction, or using your own tissue, and how that's changed a little bit in the setting of COVID. Next slide. I'm going to start first with talking about lumpectomy and oncoplastic reduction, just to remind people what that is in case they haven't experienced that. Next slide. Next one. So oncoplastic reduction is something that we can do where we combine the principles of plastic surgery using a lift or a reduction with a cancer removal surgery. What's nice and what's been actually helpful in COVID is that it's a single operation, so it requires one surgery. It's only good for people who are lumpectomy candidates. You can have a tumor pretty much in every quadrant of the breast and be able to combine this. We do plan for changes that happen for radiation, so we often make them a little bit asymmetric on purpose. And it does require coordination between breast surgeons and plastic surgeons. Dr. Oyhus and I did one today, so this is sort of what we do all the time. Next slide. And here's sort of a schematic of one type of reduction. You can see if somebody has a tumor in the upper part of the breast, in slide 1, we can actually remove that and then push the nipple tissue up into that location and give somebody a lift and also a small reduction at the time, and then we close everything out and tighten it up from down below. Next slide. This is sort of a series of photos of a patient that underwent this. You can see she had sort of more pendulous breasts in the beginning, and we performed her oncoplastic reduction, and there she is about 6 weeks post-op. Next slide. Next, when we think about things in terms of mastectomy, we really think about implant-based reconstruction or autologous, which is using your own tissue. Next slide. And the various options, you know, you can do silicone saline, you can use your own tissue from your belly, it's the most common, called a DIEP flap. You can do a combination surgery, either using your own tissue and an implant, or sometimes we do that also with just using fat. Next slide. But most surgeries begin if you're getting a mastectomy, we've sort of trended towards doing what's called a tissue expander at the mastectomy, either by going under the pectoralis muscle or above the pectoralis muscle. And this is a schematic of what that looks like. Next slide. So this is kind of a busy slide, but in terms of where you are in your process and where we walk people through, I think that this is helpful to understand because everybody has a different journey. And our goal is to get people through safely, but it often requires many steps. If you're talking about a mastectomy, you often will start with the tissue expander. There are some people who are good candidates for single stage where you do an immediate implant, but those do have a higher rate of complications. And it has to be the ideal perfect combination of tumor and breast and shape and size. But most people get a tissue expander and then they have to come back to the office for expansion. So that requires clinic visits. And then ultimately they either get that replaced with a permanent implant or they use their own tissue. And then there are things that can adjust along the time, whether or not you need radiation or chemotherapy, that can adjust your course. But in the bottom right, the other surgeries that we often do are revisions, something to the contralateral or the opposite breast. We'll do nipple reconstruction and the areola. And those are additional surgeries that are staged and done at a later time. Next slide. So what is the timing? Really, this is kind of the big thing I think COVID has done for us, is that we've adjusted a lot of the timing of our reconstruction. People like having an immediate reconstruction. The downside of that is that we do know that there's a higher risk of complications. Staged reconstruction can be lower complication rates, and most of our reconstructions are kind of done in this fashion. Delayed reconstruction is how reconstruction traditionally had been done 30 years ago. And it has the lowest rate of complications, but sometimes the aesthetics can be compromised depending on how someone's shaped. What's nice about being able to take advantage of the mastectomy skin envelope, if you will, at the time of the mastectomy, is that you can create a very natural shape and not often have to use tissue or skin from another part of your body. Next slide. So how has this really changed? Well, it's changed dramatically. But I think it really depends on where we are in the state of during the pandemic. People talk about the pandemic being sort of over or abating, and we're really not. We're just at the point we are right now, and it's different across the country, it's different across the world. In our setting here at Johns Hopkins, in March, our governor basically canceled elective surgeries. And the goal for that was really to preserve PPE, to preserve hospital beds, to maximally utilize the staff and minimize risk to patients. And we've had a lot of changes that Sue's talked about. We were still doing cancer surgeries, but initially when we were first thinking about this, we actually deferred doing a lot of tissue expanders because of the risk. Next slide. So the American Society for Plastic Surgeons actually created guidelines to help us nationally tackle this challenge, to try to figure out what is going to be a safe thing to do and what is going to be added additional risk. Because in March, none of us really knew how this was going to play out and whether or not we were going to end up like China or like Korea or like Italy. So they issued a consensus statement at the end of March, and basically at that time, in terms of tissue expander or single stage implant reconstruction or oncoplastics, they basically encouraged us to err on the side of caution and really consider things on a case-by-case basis. But all of the other surgeries that I mentioned that are the second and third stages, implant exchanges, autologous tissue, anything to the contralateral breast, or any revisions, were absolutely deferred at that time because it was really considered more elective. Next slide. And these are some of the reasons why, because we know that immediate reconstructions can have higher complications. I've got pictures here of mastectomy skin necrosis and somebody with an infection and somebody with some asymmetries. And that could cause a return to the operating room or clinic. And it's very hard to justify utilizing resources in the hospital when we were really expecting a very large onslaught and there was a loss of PPE that we were expecting. We also thought about safety for our patients. We wanted to limit the in-person visits that would be required for tissue expanders and limit returns to the operating room. And also the main reason is because we know that we can still get a very good aesthetic result with delayed reconstruction. We were doing this for years and years and years before we developed techniques to do immediate reconstruction, and we thought we could safely go back to that. Next slide. So what was done at the hospital level is that we placed surgeries in terms of tiers, in terms of urgency to be done. So tier 1 was anything urgent, emergent, or life or limb threatening. Tier 2 was something that if it wasn't done basically within about 3 months, there would be some sort of adverse outcome. And then tier 3 was pretty much everything else, which is where the majority of my practice was. So I actually got redeployed to the COVID ICU for a month and took care of patients there so I could help do my part. So early in the pandemic, we really were only doing tier 1, and that dropped the OR capacity to about 20% of what we usually do. In late May, when it appeared that we were on the right side of the curve, we started opening our ambulatory surgery centers. So the outpatient surgery centers, not at the hospital, for tier 2 surgeries, and anybody who was a healthy enough person that could be done, and it was outpatient only, come in, have surgery, and go home the same day. Just late, sort of last week in the middle of June, we have started opening things up in the inpatient hospital setting. So at the East Baltimore campus and at Bayview and Howard County, where we're doing some tier 2 surgeries here. Prior to that, it was really still just tier 1. And then we're basically going to be assessing as we go. I mean, I feel like every week or every 2 weeks or 3 weeks, our command center takes a really good close look at what are the rates in Maryland and how is the hospital adjusting and what are our supplies for PPE and how are people doing. And so we're going to be expanding as we think that this is safe. I mean, there was, in my department alone, we had about 500 surgeries that we had to cancel. I think I'd heard a number that and don't quote me on this, but something like 9,000 system-wide. So we really do have a big backlog we need to get through, and we really want to help take care of people, but we want to make sure we're doing it safe. And we're doing a constant reassessment. You know, it could be possible we get another surge in the fall and we have to drop back again. And so we're trying to do this really with data and with science and with caring. Next slide. So in terms of what we're doing now, we are doing tissue expanders and single stage implant reconstruction, and we're starting to do some replacements with implants, and particularly in people who have radiated tissue expanders, who, you know, there is a possible risk of skin compromise down the road and things like that. And we will be starting to do some revisions and contralateral procedures, but really just as we have space and capacity and things are going well. We are not doing deep flaps though yet at this time. I'm hoping that'll come out in August or September, but we just don't know. Next slide. So our mission is to continue to provide safe care for our patients during these uncertain times. I would encourage anybody who's not seeing as a patient here, just make sure you work with your board certified plastic surgeon to determine the best course for you. We will all get through this together. And in the year, we'll have a lot of interesting stories, and hopefully, I think that everybody's going to end up safe and well taken care of. And I'll answer any questions. Thank you.
Thank you so much, Dr. Broderick. Actually, we're going to go on to Dr. Oyhoth, if that's okay, and hopefully we'll have time for questions at the very end. Dr. Broderick, I know you need to be back in the OR, so if you can't join us for questions. If you have questions for Dr. Broderick, please send them our way, and we'll try to get to them, whether other providers or I can email Dr. Broderick. Thank you so much for a great presentation. Really helpful to sort of, in a nutshell, we'll all get through this together, but there are going to be some constant reassessments going on in the next several months. So thank you so much for that. Dr. Oyhouse, I'd like to switch gears back to you if we can, try to see if we can get your slides to work. Can you hear us now, Dr. Oyhouse? Okay. Not sure why we can't hear you, Dr. Oyhouse. Jenny, let's go ahead, I guess, on to our next presenter. Let's switch to Dr. Karen Smith. Dr. Smith will be here talking to us about HER2 positive breast cancer. Dr. Smith, I'm going to turn it over to you. Again, Dr. Broderick, thank you very much.
Hi, everybody. Are you able to hear me?
You can, thank you.
Excellent. All right. So I am one of 3 breast cancer medical oncologists who's going to be presenting very briefly today about one of the 3 different types of breast cancer and how we approach a newly diagnosed woman who's going through the treatment decision process during this turbulent time. Next slide, please. So first, just a little bit of information about what do we even know about cancer and COVID-19 and how they interact. Part of what led to a lot of scare early on in all of this is that some of the data coming out from China suggested that individuals with cancer had higher risks of even getting COVID, and that if they got COVID and caught the coronavirus, they were much more likely to get really sick from it and to even pass away from it. And of concern, that also suggested that the hospital setting was a source for transmission and catching the virus. So this led to a lot of immediate changes and cutting back in some of the video visits and things like that to try to ensure safety. We've done some more recent larger studies in Western populations that have just been published, and they have confirmed that it does seem that the risks of getting really sick are greater in an individual who has cancer and who catches the coronavirus, but especially if they have underlying health conditions. It does not seem that the cancer treatment itself is associated with risk, even the chemotherapy, but what's really important is that we take every step necessary to avoid exposure or minimize exposure. But we have to balance that with treating the breast cancer itself. The hard part about some of this data is that it's very recent, it's very short-term follow-up, and most of the patients in these studies did not have breast cancer. So we actually don't know very much about breast cancer patients and COVID risk at all. Next slide. So that makes treatment decision-making very difficult. And treatment decisions can be difficult in newly diagnosed breast cancer anyway, and we're always weighing risks and benefits and trying to pick the best path forward for each patient. So the things that we have to sort of think about are, what's the risk of cancer recurrence and what do we need to do to reduce that as much as possible? And then on the flip side, we now have to consider, well, what's the risk of getting exposed to the virus by coming to the hospital for the treatments? And what about suppressing the immune system? How could that possibly have a negative effect? So it's one more factor that we have to consider in the decision. And we don't want to do aggressive cancer therapies if they're not likely to have a big benefit. If the risks of COVID are going to outweigh the benefits of the treatment, we shouldn't be doing that. But for most people, that's not actually the case. Next slide. So as I mentioned at the beginning, there's 3 main subtypes of breast cancer, and I'm going to talk about HER2 positive, which is just one of the 3. This is a marker that's overexpressed in about 20 to 30% of breast cancers, and there's 3 ways that we look under the microscope to define it. One is called this IHC test that's 3+, or a FISH test. The key implication here is that for patients who have HER2 positive breast cancer, we want to be giving anti-HER2 therapy as a part of the treatment. And that's typically an intravenous therapy that's given over an extended period of time, most often every 3 weeks and most often for a year. And we'll usually combine that with chemotherapy. Next slide. So this is a very complicated slide that is by no means for anybody to read in any great detail, but it basically shows us that this is our approach to it, and it shows you that the approach and the treatment strategy is going to be different even within the HER2 positive category, and it's going to depend on the extent of cancer. So the treatment strategy for someone with a larger tumor or one that has spread to the nodes is going to be different from one that is smaller. Next slide. So what about women who are diagnosed with a small HER2 positive cancer that has not spread to the nodes? In this case, we are often recommending surgery first if surgery is feasible, even during the pandemic. And the reason is that then we can figure out, confirm the size and make sure that it is indeed small and the lymph nodes are indeed negative. And if that's the case, we may be able to cut back on our systemic treatment. So give less chemo, less HER2 targeted therapy, or potentially even none, with the goal of potentially reducing the risk of being exposed to the hospital and that kind of thing. So it gives us a little bit more information, but it's a little bit different for someone who has a larger cancer. So if you could go to the next slide. So in the setting of a larger cancer, we know that there's benefit from doing the chemo and the HER2 targeted therapy first. And we think that even during the pandemic, we should be doing this because the risks associated with the cancer are greater than the risks associated with coming to the hospital and COVID. And we know that the benefits of the treatment are really, really great, that this treatment works and it shrinks the cancer. So we typically do that first, chemotherapy plus 2 HER2 targeted therapies, and then we do surgery, and then we are able to give more HER2 targeted therapy to finish up that 1 year after surgery. But what we do is we adapt it based on the amount of cancer that we find at surgery. So we individualize it. Next slide. So there are some general principles. So what we're trying to do is do as much of our usual breast cancer treatment for HER2 positive during the pandemic as possible, because this is typically a curable disease that we have very effective therapies for. But there are some changes that we're trying to make to potentially reduce exposure to the virus. The first is that there is some data that suggests that the total course of HER2 targeted therapy can be shortened to 6 or 7 months instead of 12 months. So that's something that we are considering on an individual basis. Typically, as I said, the HER2 targeted therapy is given every 3 weeks. For a couple of the drugs, there's some data that suggests that maybe you can give it a little bit less often. The potential advantage to that is just fewer visits to the hospital, kind of space it out a bit. The other things that we're doing is we are trying to boost the immune system as much as possible during chemotherapy. So we're giving growth factor boosters more frequently, and we are using fewer steroids because they can suppress the immune system. Oftentimes during HER2 targeted therapy, we have to monitor the heart, and we kind of routinely do that every 3 months. But in women who have no underlying heart problems, one reasonable thought is to maybe do that a little bit less often and just cut down on the number of visits to the hospital by eliminating some of those extra tests. For HER2 positive breast cancer, we still think that radiation, if it's indicated, should be given, and it should not be delayed until after the pandemic. And similarly, that hormonal therapy should be given. Next slide. So that is all I have. Overall, I just want to reiterate that we work together with our surgeons and our radiation doctors to come up with the best plan and the best sequence of therapy for each patient. And that at this point, we have such strong procedures and things in place to really ensure that every patient is getting through their treatment and getting through it in as safe a way as possible. Thank you.
Thank you so much, Dr. Smith. That was really helpful. We're going to switch gears again and try Dr. Oiho, see if we can get him on board, and then we'll go back to some more medical oncology talks. Dr. Oiho,
can you hear me?
Yay, we can hear you.
Yay! Yeah, it took unplugging and replugging back in. Okay.
Very good. Thank you.
Okay, so I'll just launch in, and a lot has changed since early March, and I think what stands out to me most and what was most shocking and disturbing was having people, mostly women, coming to the clinic with a newly diagnosed breast cancer all by themselves. Some of them would call a significant other or a relative, and we do a video conference together. And then the next thing was they would show up in the operating room all by themselves, and that it's like an extra level of stress, and it seems a little more difficult. Some people are doing great with it, but it's very, very difficult for others. And the other thing that's really been kind of different and disturbing was putting together lists of patients that were scheduled for surgery, and then deciding who really needs to go now and who can wait, and then how can we make it safe for the patients to wait. And as the other speakers have brought up, there's been new rules and regulations put into place in this COVID era. And the guiding principle behind all those regulations is to protect the patients and the healthcare providers so that we're not causing infections wherever we gather. Overall, we want to reduce the spread of COVID-19 and preserve personal protective equipment in case there is a very challenging outbreak. Next slide. The American College of Surgeons is a national group that came out with guidelines that the governors often followed in terms of what surgery should be done and what shouldn't be done. And that's kind of at the heart of where elective surgery was canceled in early March. And the way those guidelines were established, it was based on how severely the COVID cases are taxing resources. The whole idea was to protect the hospitals so that they didn't become unable to function anymore. Next slide. So the American College of Surgeons guidelines came out very early in March. And that blue line is the cases in New York, and the orange line is the cases in Maryland at the time. And so those guidelines came out very early when the cases were rising exponentially. And then we all saw New York get completely saturated with COVID cases, and their hospitals fill up and stretch to beyond what was tolerable. And I think we were all afraid that the same thing would happen here. And that's why the guidelines went into place, the stay-at-home orders, canceling elective surgery. But then over time, Maryland did not become New York, and our cases were spaced out over a much longer period. The hospital never really did get overrun and saturated. So the point being that there are regional differences, and so the guidelines are great for establishing the baseline for the conversation, but each locale needs to come up with what's best in their, depending on their COVID levels. Next slide, Jenny. So the American College of Surgeons guidelines divided the COVID infections or COVID pandemic into 3 phases. They recognized there'd be a phase where you have a few COVID cases, but you have plenty of capacity in your hospital. Even under that circumstance, they said we should only operate on the highest risk breast cancers. If it's like a small estrogen receptor positive breast cancer, maybe we should keep them out of the OR and just treat them with tamoxifen or an anti-hormonal medicine and operate later. And they said, don't do any benign surgery. If it's like a fibroadenoma or just some benign finding on a core biopsy, put that on hold as well. And then the other 2 phases, there's the second phase where you have many COVID cases and the hospital is likely to become saturated. They said quit operating on breast cancer altogether, operate only on life-threatening conditions, maybe if we're bleeding or infection in a breast. And then the same for when you're saturated, like New York became. Thankfully, we never really got out of phase 1. We perked along at kind of flat levels for a long time, and now things are actually declining and getting better. Next slide. What did we actually see? What was the impact we saw for those 3 months? They stopped doing screening mammography here, and so early detection paused. We stopped seeing any new patients who had small little lumps found on a mammogram and that were diagnosed on a core biopsy. Instead, you were only seeing patients that had a lump or some bloody discharge or had some symptom of a breast cancer. There was, Dr. Broderick already talked about the suspension in breast reconstruction. And there were patients who needed mastectomies at that time, but we weren't doing any reconstruction. And so they had to make the decision whether they were going to go on medicines like tamoxifen and then delay their surgery. And many of those patients said, no, I'm not waiting. I want my mastectomy. I'll skip the reconstruction for now and we'll do it later. That was a big change from the way we've been functioning because we've always depended so much on our plastic surgery colleagues for immediate reconstruction. But thankfully, at the beginning of May, the reconstruction resumed and we're getting a bit closer to normal on that type of things. So like I said, there were some patients with early low-risk breast cancers that went on medications. Overall, we did not accumulate a large backlog of breast surgery patients that are waiting to get on the surgery schedule. We have some, but mostly we continued operating because we never did get into that really stressed hospital phase, and it was possible to continue doing the breast cancer surgery. Next slide. Currently, newly diagnosed patients are evaluated promptly, and surgery can usually be scheduled quickly. What really has changed is that now we're competing for OR time with general surgeons who did develop a big backlog when they couldn't do their elective gallbladders or hernia repairs or things like that. So it's a little more challenging to get OR time right now, but we're working through it. And another thing I've noticed is the infection control measures have slowed everything down. So we can actually do fewer cases in the course of a day than we used to do. So we become a little less efficient. Next slide. We just want to highlight that one of the main guiding principles for the rules that we've been following is that we want to reduce the spread of the virus. And that means limiting the number of people coming to the hospital. We've postponed most routine follow-up visits, although those are starting to be reintroduced. We've had to redesign the waiting areas to respect social distancing. Telemedicine is done if possible, but in breast surgery, the clinical exam is super important. So for most of the breast surgery patients, we'll want a face-to-face visit, although we've been doing some telemedicine for some indications. And then no visitors in the clinics or the OR. And again, I started with that, and that's been kind of the most disturbing thing, I think, for me and for the patients as well. And then last slide, predicting the future, as everybody has been saying, COVID-19 is going to be with us for the foreseeable future. It's not going to be done in a couple of months. And we're learning how to operate in this new normal. I just want to emphasize that the way we operate in this new normal is social distancing, hand washing, and masks. And the whole idea is that we avoid entering that American College of Surgeons phase 2, where hospital resources are starting to be strained and we can't take care of even early breast cancers in the operating room anymore. And I think Maryland's done really well avoiding that phase 2 and continuing to operate. So we are currently performing the full range of malignant and benign breast surgeries, and Dr. Broderick has covered the reconstruction changes. So, and that's all I've got. Thank you.
Thank you so much, Dr. Whitehouse. Of course, always well worth the wait. I appreciate you being patient as we figured out the technology issues. I'm going to switch gears again now. We're going to turn it over to Dr. Jessica Tao. Dr. Tao is going to talk to us about triple-negative breast cancer and the changes with the COVID epidemic.
Thank you so much, Shalissa, and I appreciate this opportunity to be able to share some of our approach to triple-negative breast cancer. Next slide, please, Jenny. And so briefly, triple-negative breast cancer refers to breast cancer that lacks expression of the estrogen receptor, progesterone receptor, and the HER2 receptor. These are the three main biomarkers that we're looking at when we determine the subtype of the breast cancer. So in other words, this is ER, PR, and HER2 negative breast cancer. And that becomes relevant because with the absence of these three biomarkers, the mainstay of treatment oftentimes for triple-negative breast cancer is chemotherapy. Triple-negative breast cancer accounts for about 10 to 15% of all breast cancers. Next slide. And when we're thinking about the general treatment paradigms of TNBC, that is early stage, or that has not spread beyond the breast and the nearby lymph nodes. We are often considering a combined modality approach with surgery, chemotherapy, and radiation. And overall, when we're thinking about how to approach treatment, we rely on the stage or the extent of the cancer. And specifically, which I talk about in the next couple of slides, in clinical stage, this extent is based on the results of our physical exam, sometimes our imaging, and certain features of the cancer. In the pathologic stage, the estimate of the cancer's extent is determined based on what's learned after the surgery itself. Our approach to clinical stage 1 triple negative breast cancer, or earlier stage triple negative breast cancer, is in general to proceed with upfront surgery. This was true before the pandemic and continues to be after the pandemic, whereby patients with early stage triple negative breast cancer are prioritized to the OR. After upfront surgery, we'll have pathologic staging information. Patients with lower pathologic stage, so these are smaller tumors, often with no lymph node involvement. Based on those results, we often discuss chemotherapy and then radiation as indicated. And those with higher, can you go back one? Thank you. And in the bottom part of the graph, you can see the those with higher pathologic stage or bigger tumors, or those with lymph node involvement. We're often discussing chemotherapy and followed by radiation as indicated. We're still, in most cases, recommending chemotherapy occur in a timely manner within about 2 months after surgery. And we're not suggesting that we delay radiation therapy at this time due to concerns of COVID-19, given the benefits of treating this cancer. In higher stage or clinical stage 2 or 3 triple negative breast cancer, we often take what's called a neoadjuvant approach, which means giving chemotherapy before surgery, and that is usually done for 2 reasons. One is to enable a better surgery, to use chemotherapy to reduce the size of the tumor to enable a better surgery, and secondly, to also gain information about the cancer itself. After chemotherapy, surgery is part of the treatment paradigm. And then after surgery, we again receive more pathologic information, and radiation may be indicated, and possibly more chemotherapy afterwards if these cancer cells remain. I had discussed early stage triple negative breast cancer. When it comes to metastatic triple negative breast cancer, the general treatment approach is typically sequential therapy, which means chemotherapy given in succession. And as Dr. Smith had highlighted before, much of the type of chemotherapy and the way that we're administering chemotherapy is applicable to both HER2 positive disease and triple negative breast cancer. So we consider medicines, for example, that could be administered at longer intervals, monthly intervals, for example, in order to reduce the number of visits that patients have to come into the center for, or trying to prioritize oral regimens that could be an option. I guess the bottom line of all of this is that, as in a lot of our medical oncology care, the treatment decisions are tailored to each person, and it's an individual discussion that happens between you, the patient, and us, and the overarching principle that we're trying to take a very, very thoughtful approach to help bring safe and effective care.
Thank you so much, Dr. Tao. That was wonderful. We're going to move on to medical oncologist, Dr. Cesar Santamaria, who will be talking to us about ER-positive breast cancer.
Great. Thank you, Alyssa. So I'll just go ahead and jump in since I see we're getting a little tight on time. So I think some of the previous speakers already touched on this, but just in terms of breast cancer basics, this is a very common disease with, over 270,000 cases a year expected in 2020, and unfortunately 42,000 deaths per year in 2020 as well. Lifetime prevalence of 1 in 8. So very common disease. And unfortunately, the way we think about diagnosing it is, I always tell patients there's really two key parts to the diagnosis: the stage and the subtype of the breast cancer. So I'll be focusing today's discussion on early stage breast cancer. So that means breast cancer that's just limited to the breast or lymph nodes nearby. And I'll be focusing today's talk on the hormone positive breast cancers. There's two hormone receptors, the estrogen and progesterone receptors. And that defines this subtype. Specifically, I'll be focusing on the hormone receptor positive, HER2 negative subtype, since those who are HER2 positive we typically treat along a HER2 positive paradigm. Next slide. And just what does this mean pathologically? We look at, under the microscope, these cancer cells and stain them for the hormone receptors, and you can see an example on the screen there. We technically define hormone receptor positivity as at least 1% of cell staining, but we typically consider these cancers to be more hormone sensitive at higher percent levels. Next slide, which kind of goes into a little bit how we further define hormone receptor positive breast cancers. It's really a spectrum of disease. On one end, we have what we call on the medical side a luminal A kind of hormone receptor positive breast cancer. These are the ones that are very sensitive to anti-hormone treatments. They're typically more indolent. They're not necessarily as sensitive to chemotherapy. On the other side of the spectrum, what we call the luminal B type breast cancers, and these are typically more aggressive. They're less sensitive to anti-hormone treatments, and chemotherapy plays a more important role. So while we can kind of clue in what kind of, where the hormone, where in the spectrum the diagnosis falls, there are some more refined techniques of understanding that with certain molecular tests like the Oncotype test or the MammaPrint test, and these are tests that look at different genes and how they're expressed, and there's algorithms to kind of give patients and their doctors a score that's either low or high or somewhere in between, that can help inform the decision for chemotherapy. So next slide. So, and I think, again, previous speakers touched on this. What are some of the considerations as we apply our treatment strategies to hormone receptor positive early stage patients during COVID? Some of the key principles are minimizing visits, just limiting in-person exposure to our healthcare center, minimizing immunosuppression. So when we do have to use chemotherapy, we want to really reconsider there will be a significant benefit to doing chemotherapy. And then earlier on in the pandemic, particularly, the potential for delays in surgery, and how can we use some of our treatments to kind of treat patients if surgery is going to be delayed to kind of hold them over, so to speak, or possibly even get responses to help with surgery. Next slide. So this is a very busy slide. Oh, I don't know why it came out all jumbled like this, but and this is based on our internal guidelines that was previously mentioned. Hopefully will be published soon. I think the COVID pandemic really forces us to take another look really at how we look at these breast cancers in terms of their biological risk, because that really defines the kind of treatment we're going to think about for them. So while for the most part, for hormone receptor positive breast cancers, we do tend to use surgery as an upfront treatment. For those who have low risk biologically, so maybe they have a low grade, very high ER/PR breast cancer, perhaps they have a low oncotype or a low mammoprint. These are patients where we might consider using just anti-hormone therapy for several months prior to surgery. And that's a way of really effectively, holding patients over on treatment, but sometimes in certain cases, this previous treatment before the surgery can positively impact the surgery. If we're able to get a good response, we might be able to do less surgery. That's particularly something that might be relevant in patients who have node-positive disease, where the breast cancer spread to the lymph nodes. If they get a really good response there may be less surgery that they may be able to do. And then for patients who do have the higher risk biology, particularly those who have larger tumors or have lymph node positive tumors, I think these are patients who do benefit from doing chemotherapy up front. We know that we're going to be recommending chemotherapy either way, and by giving it up front, we can potentially even positively affect the surgery. Next slide. And this just summarizes again the way we think low and high risk features. I won't go through this slide, but I'll go ahead and end here just for the sake of time.
Thank you so much, Dr. Santamaria. We're going to move into our final presenter. As was already mentioned, we are running a little bit close on time. We're going to stick around for a little bit longer, so if you guys can stick with us, great. Otherwise, we'll be sending out the recorded link. Also want to remind people, feel free to send me questions, and we'll get to a couple questions at the end of the presentation. Our last speaker today is Dr. Sarah Alcorn. She is a radiation oncologist here in the Department of Radiation Oncology. Dr. Alcorn, can you hear us?
Yes.
Great, wonderful. Thank you very much.
All right, so thank you for the introduction. I have no disclosures to report. Next. So what is radiation therapy? It's the use of different kinds of high energy rays or particles that can help kill cancer cells. And there's a few different sorts, but the sorts you generally hear about for breast radiation include X-rays, which are also called photons, protons, and electron radiation. And the general way that, the general way that we use these tools is using a machine that you see on the right-hand side there, and that's Dr. Ezrari, one of the other breast radiation oncologists. And that blue pillow behind her is something that a person lays on during their treatment for radiation. And the silver and white arm of that machine rotate around the person to deliver the radiation beam. And so it goes through the tissues that we're targeting, and if it encounters a cancer cell hidden within those tissues, it can cause damage to that cancer cell at the DNA or genetic level, and that can cause the cancer cell to die. And the person laying on that table doesn't hear, feel, taste, smell. They have no indication that radiation is being delivered other than a little buzz the machine has. Next slide. So when is radiation generally delivered? It does, of course, depend on the clinical situation. So after a lumpectomy or a breast conserving surgery, usually radiation therapy is needed, and there's some exceptions to that rule. Next. After mastectomy, it is sometimes needed. It depends a little bit more about what is found at the time of surgery. Next. And how we generally deliver radiation therapy differs as well, depending on what we're targeting and the clinical situation. So after a lumpectomy, usually people are receiving radiation from anywhere from 3 to 6 weeks. That's daily, Monday through Friday. Each treatment lasts about 10 minutes, up to about 20 minutes on certain days. And after mastectomy, people usually are receiving radiation for 5 to 6 weeks in time, daily, Monday through Friday. Next. So how do we choose a radiation treatment plan and dose that's best for someone? It's generally a balance in the general sense between radiation dose that is sufficient to kill cancer cells, but that does not have a high risk of causing side effects to the normal tissues nearby, like the skin, the muscle, and the bone around the breast. Next. Next slide. If we use too much radiation dose per day, give it too quickly, we can actually change that balance such that the side effects may not be worth it in light of any added benefit in terms of killing cancer. So our balance is to try to equal out that cancer kill and the side effect between our treatment regimens. Next. And the ways that we can differentially affect killing of cancer and minimizing side effects is by changing some of the ways we deliver the radiation. So we can use a different radiation dose per day over a total different number of treatments. You might have seen that for the whole breast, or sorry, for after a lumpectomy, we might give radiation anywhere from 3 to 6 weeks. It's actually about the same total dose. It's just more radiation per day when we deliver it in the 3-week regimen. And we also may use different types of radiation, as you heard, the X-rays versus the protons versus the electrons. Next slide. But then the COVID pandemic has added another feature into this balance, and that is the need for us to reduce possible exposures of people to that virus. Next. And in general, our goals then now become to, in addition to killing cancer cells and minimizing side effects, we need to think about ways we can shorten the number of treatments or the time per treatment. We need to be really conscientious about the techniques that we use during radiotherapy. So for example, if someone has a left-sided breast cancer, I might ask them to do a special procedure in non-COVID times where they hold their breath, and that breath hold procedure tends to move the heart away from the targeted chest wall or breast area on the left. Now, because a breath hold procedure involves a lot of breathing, and we know that the COVID-19 virus is spread through respiration, we are trying to minimize our use of that, and that makes us have to use other techniques, including things like proton radiation, and consider that more during the COVID times. And we've also, in certain cases, been able to delay radiation if someone has a hormone receptor positive disease and might be taking the hormonal therapy. We may be able to have them take that therapy for a bit of time to get them through a peak in the COVID pandemic and delay radiation for a period of time as well. Next. So you saw that there is a range of durations of radiation we can give, and we now need to consider ways in which we can shorten radiation courses. Why don't we always just use the shortest possible course? It's because the longer courses tend to be the ones that have been studied more thoroughly over time. We've been using them for years and years, and we have a very good understanding of how good they are at killing cancer cells and also what kind of risks of side effects people might have. The shorter treatments and things like proton radiation are somewhat still in the experimental phase in certain cases. We have not been able to follow patients treated that way for, say, over 10 years. And then we're not 100% quite as sure how good they are at killing cancer or how they affect side effect risks as compared to our standard courses. But in many, many cases, we can use data available and our clinical knowledge to estimate that the risk of differences between a longer and a shorter plan may be very small for certain people, and that risk may be smaller than the risk of COVID. Next. So in certain cases, what are some of the other options we can use to reduce COVID exposure during radiation? So for the lumpectomy, next. If we're not treating lymph nodes, we're just treating the breast area, our standard radiation dose is a daily radiation given for 3 to 4 weeks in time, and generally treating the whole breast area. There is a certain subset of people who are age 70 and over who have early stage, small, hormone positive breast cancer, and they're going to take hormonal therapy that even right now, even before COVID, we felt very comfortable skipping radiation. Now that's the standard approach, and then in the COVID crisis, in order to shorten treatment times, we have been leaning more heavily on another option, which does not treat the whole breast, but treats just part of the breast, the highest risk part. And in certain people, this is a very reasonable approach to take. And that can be delivered every other day for 2 weeks, so in 5 treatments, or on a twice daily basis for 5 days as well. We've also used some evidence to support decreasing the age for which we can skip radiation from 70 to 65. So then those are the options that may be available to people right now for COVID reasons. When we do need to treat the lymph nodes, that's a larger treatment area. So that is why standardly we use a longer treatment course with a lower dose per day. But we do have some evidence from abroad, places including China and in Canada, where we see that a shorter radiation approach may be very reasonable, so a 4-week treatment plan, and we can discuss the pros and cons of that with people to shorten the time they're in our healthcare system. Another option for those folks with left-sided breast tumors who I would normally use a breath hold procedure for protection of the heart, they may be someone who I'm now newly considering proton radiation for. Next. And so what about after mastectomy? Next. Fairly similar to the slide you just saw, it's usually treatment areas, a fairly large treatment area in the realm of breast treatment. So we use standardly x-rays daily for 5 to 6 weeks. But in this COVID crisis, we again have some data from other sources that suggest that for many people, it may be very reasonable to use a 4-week course instead. So we can discuss and use that option in certain people. And for left-sided tumors, once again, if the breath hold procedure is needed to protect the heart, instead of using that, we may recommend protons. Next. So in summary, when we're choosing a radiation treatment plan, we're thinking about this balance of killing cancer cells and balancing that with the risks of side effects a person may experience from our therapy. And now we have this new added consideration of minimizing risk of COVID exposure during treatment. So when you meet with your radiation oncologist, we will certainly be spending time talking about the balance of these factors and how we can best choose a treatment plan that's very individualized. Not everyone's going to be eligible for a shorter course of treatment given some clinical features, so we'll help you understand that as well. Next. And we have an academic paper from our department about how we dealt with the COVID crisis in a radiation oncology clinic setting. And there's an entire table spent talking about breast radiotherapy for anyone interested. Thanks.
Thank you so much, Dr. Alcorn. I want to go ahead and we're going to have to end this presentation. I apologize, but several of our speakers have messaged me saying that they're unable, given all the business that's going on right now, to stick around. So I do apologize, but do hope that you enjoyed today's presentation. I'd like to go ahead and thank Dr. Oyhos, Dr. Broderick, Dr. Smith, Dr. Tao, Dr. Santamaria, and Dr. Alcorn, and a special thank you to to Mrs. Longley, who reminded us why we do what we do every day, and to being so candid and really to remind us that the glass is more full than empty right now. So I do appreciate that. Please take a moment and fill out our satisfaction survey that you see right here. It'll only take a second, and I will also be emailing this out. And finally, next slide, Jenny. Just to remind you, we have a couple of webinars still coming up. Next Friday, the same time, we have our final webinar in this 3-part series, Breast Cancer Follow-Up and Survivorship Care in the COVID Epidemic. Please join us for that. Talk about next steps after active treatment is wrapping up. And finally, in July, we have a webinar on managing sleep and fatigue, and then in August, one on mindfulness and meditation. To register for any of these webinars, please click the link that you see here. It's the same link that you used to register for this webinar. Again, I'd like to thank you for attending today. Appreciate your patience with some of our technical issues and apologize that we didn't get to questions, but hope that you join us next week and hopefully we'll get to some questions then. Thanks so much. Take care. Have a great day.